Benefits and the Challenges of Multinational Clinical Research in Cancer by Professor David Cameron from UK.
Good afternoon, everybody. Thank you very much for inviting me. It's an honour and a pleasure to be here to talk to you about what the EORTC, and in particular, the EORTC Breast Group has been doing. Now, I've actually got 3 talks, and I've tried to link them together. Yeah, the next one. In a sense, my first talk, which for many of you may not say anything new, but I suspect there will be some new data in here that you may not be aware of. The first talk will look at, in a sense, at why, what the benefits and challenges are of doing research, particularly multinational, but research in cancer. The second talk will focus on the MIND-ATTACK trial, which is a big, important, fairly groundbreaking study that the EORTC has conducted in collaboration with other groups. And then my third talk will focus, in a sense, on what do we do with trials? How do we actually move the whole area forward? And I clearly recognise that I'm talking to an audience who may well have done more clinical trials than I have. So some of what I say may not be new. But bear with me, because I'm trying to create a whole story about what I think is going on. We recognise as physicians that if we wish to treat our patients with a treatment, we need to have some evidence for that. And so it's become, certainly in many parts of the world, a buzzword that we should only practice and therefore only fund evidence-based medicine. And what this cartoon points out is that there are a number of things we do and have done for a long time in medicine where in fact the evidence base is not as solid as we would like. And what we've been trying to do in cancer, and in many times have led the way in medicine, is to actually get a robust evidence base for as much of what we do as we possibly can, because then we know we're giving patients the right and most effective treatment. One of the tragedies, and I speak as a medical oncologist, one of the tragedies is that the majority of studies in cancer involve drugs. In the UK portfolio, it's around 85%. But I'm happy to admit in front of surgeons, particularly in the world of breast cancer, that the breast surgeons cure more people than I do. So where are the surgical trials? There have been a few very important, very pivotal trials run by many groups, including the EORTC. But surgical trials are a small part of a research portfolio. And there are a lot of reasons for that. Similarly with radiotherapy, another very important curative modality. Again, radiotherapy studies tend to be in a minority. And there are a whole series of other areas of how we treat patients that have not been subjected to the same level of research as the drug treatments in cancer. But in a way, there's almost been an excessive focus. Now, the model I've got here of clinical trials, phase 1 to phase 4, is largely taken from the drug world, but actually it applies to other treatment modalities as well. So phase 1 trials, which really should be conducted in specialist centres, ask a simple question. Can we give this new treatment, usually a drug, to patients safely? We're not yet looking for how effective it is. It's simply, can we find out how effective this drug might be because we've worked out how to give the drug safely? What are the side effects and how do we manage them? Phase 2, very much around a cohort of patients, increasingly randomised phase 2s, to look for the signal that the new treatment, whether it's a drug, radiotherapy technique, surgical operation, may actually have more effect than previous ones. But increasingly, particularly in drug development and in other areas of treatment, phase 1 and phase 2 are being merged. We talk about phase 1b, phase 2a. We talk about phase 1/phase 2 studies. This classic distinction is gradually being lost. The phase 3 trial remains in many ways the most important because this is the study that will tell us, is this new treatment that looked fantastic in preclinical work, looked fantastic in phase 1, had wonderful effects in phase 2, is it actually better than what we do now? And so a lot of the research narrows down to the phase 3 trial, which is the final point where we say, should we or should we not take forward this new treatment? For drugs, that's all about drug registration and licensing, FDA, EMEA, and then obviously each country has its own licensing process. But the same should apply to surgery and radiotherapy. We can develop new techniques, just like we can develop new drugs. But to know that they're better or safer or less toxic requires a phase 3 study. Otherwise, we're just working on guesswork, and we're not always right. And if we want to look for one example, we just look in the treatment of breast cancer with high-dose chemotherapy. There's a story of an awful lot of patients given a very toxic, very tough treatment based on presumptions and indirect comparisons that made people think this really is better. And apart from one study which appeared to be fraudulent, the randomized trials have not shown us that high-dose chemotherapy is better. Those randomized trials should have been done earlier. And I think we need to think about that with whatever treatment we're taking forward. And finally, and this is important, is the phase 4 study, which is, yes, we know it's better in the trial. What actually happens in real life? Because sometimes in real life, drugs and treatments turn out to be less effective. Sometimes, and I think trastuzumab is a good example, actually in metastatic breast cancer, trastuzumab is arguably better than we expected from the pivotal trial. And increasingly, the health economics as to whether a drug should be used or a treatment should be used, given that it works but may be expensive, gets built in there. And the EURTC particularly used to do phase 1 studies, has by and large stopped doing that. They're done in a small number of highly expert centres. The EURTC's main focus, it's fair to say, is in the phase 3 practice-changing studies with translational correlative science. We do phase 2 studies, particularly if they lead into or feed phase 3 designs. I think it's fair to say we very rarely do phase 4 studies, although we have done them. So our focus is mostly phase 3 and to some extent phase 2, with a very heavy emphasis, increasingly so, on correlative science. So phase 1, phase 2 requires expertise. It's not to be done in every hospital, in any country in the world. You need to be careful about patient observation. You need to have clear communication channels and an understanding of everybody involved, not just the physician or surgeon who saw the patient, but the whole system. To look out for things that you don't expect, the toxicity that you would never think was a drug effect, because otherwise they get missed and they don't turn up till later. We need rigorous data collection, obsessive attendance to protocols, operating procedures, standard operating procedures. So these really are for specialist centres. Most European countries will only have 5 or 10 centres that are really good at phase 1 trials. And increasingly, even in phase 1 studies, and especially in phase 2s, we want tissue from the patients to understand the translational science. And they're labour intensive. In my hospital, we have a lead investigator for phase 1 studies. She puts 20 or 30 patients a year in phase 1 trials. That's it. That's her whole workload. That's widely the case. And it's very few centres that will recruit phase 1 patients into the hundreds. However, phase 3 and phase 4 trials are much more geared at real life. And they need to go to centres where there are lots of patients, so people get familiar with the new treatments, and increasingly embed them in standard of care. So many of our adjuvant chemotherapy trials for breast cancer are embedded in routine care. We're just simply comparing one treatment with another in the normal process of care. Picking up toxicities is important because even at this stage we find new findings. It's important to stick to protocol, do standardized assessments, and increasingly, even in phase 3 and phase 4 trials, getting access to tumour tissue and blood samples from the patients is becoming more and more standard. And again, the EURTC, as Carlo pointed out, has over the last 5 or 10 years really made this an increasing focus of what we're trying to do. And we may increasingly ask for additional data like health economics and quality of life. So why do we do this? Well, the bottom line, and I quote these various things here, the bottom line is apart from generating new data, there is evidence that hospitals that do clinical research treat all their patients better, not just those in the trial. Now, the first quote came from a colleague of mine. Why do we have all these research nurses? If money's tight, let's get rid of them and just spend it on drugs. And my counter-argument was, well, actually, doing research improves the outcome for all our patients. And let me take you through some data. So, first comparison comes from Germany. And this is within the German breast group some years ago, asking the question as to whether patients who went into trials, were they the ones who would benefit? So you can see here that patients who were eligible for study could choose. On the upper curve, they agreed to be randomized between two treatments. The bottom part, those who declined the trial, in consultation with their physician, would choose one or other of the trial treatments. And so if being put into a clinical trial meant you did better, we would see a difference between those who went into the trial and those who did not. And the answer on these curves, the one on the right is slightly complicated, but the one on the left is very clear. For the first trial, the outcome was identical, whether they went into the trial or whether they didn't. Bearing in mind that everybody in the trial and everybody outside the trial got one of two treatments. So they were essentially treated the same, but they declined the trial. It made no difference to their outcome. So this data suggests it's not that going into the trial that actually benefits patients. One of the most important observations comes from Finland. So the Finnish leukemia group, between 1979 and 1985, introduced clinical trials in multiple myeloma across the majority of hospitals. So this is a natural experiment. It's not randomized, it's a natural experiment. So in the 17 districts where trials were introduced, the 5-year survival from myeloma went from 24% to 38%. That's a huge improvement, a 50% improvement in outcome where the trials were done. Where the trials were not done, there was absolutely no improvement in outcome. Now, this is not because the treatments in the trials were so much better. It's because by doing the trials, the whole service improved the quality of what it offered patients. So the people who went in the trials or did not go in the trials got better treatment because the hospitals, the departments, got better at doing what they did every day. There's data from Germany again in ovarian cancer, looking at the hospitals which did and didn't take part in trials. The solid line is the hospitals that took part in ovarian cancer trials, the dotted line those that did not. And at 2 years, there's a huge improvement in survival if you were treated in a hospital that took part in clinical trials. Not many ovarian cancer trials have a hazard ratio of 1.6. But taking part, or rather being treated in a hospital that did research, made a huge difference to outcome. And the answer was not because the drugs were better, but to be frank, because the surgeons took more care over the operation, because to go into the trials, they had to have reduced or less than 10 millimeters of residual tumor. So everybody worked harder to do better surgery. And that's probably what improved the outcome. The actual drug trials probably made much less difference. And very recently, this data was presented about a month ago in the UK. It's colorectal cancer, so it's yet another cancer, but it's the same story. And over the last 10 years, we've had government funding to do clinical research within the NHS on a scale we've not had before in the UK. And this graph looks at recruitment of colorectal cancer patients to academic trials. These are not commercial drug trials, these are academic studies. And in red, you can see the trials where there was an intervention, changing the treatments, surgical, radiotherapy, drugs. And in blue, which was the majority of the recruitment to observational studies, understanding the genomics, understanding methods of follow-up, that kind of treatment. So we had 31,000 patients over a 9-year period recruited to colorectal cancer trials in the UK, of which about 1/3, 11,000, were into trials where there was a different intervention. So the majority of patients did not have their treatment changed for being in the trial. And we linked these data to outcome data for all colorectal cancer patients, all 210,000 diagnosed in the same period, across the same hospitals. So it's the same. We're not looking now at the outcome of the patients in the trials, but all the patients treated in the hospitals that took part. And we asked the question, does it matter how much research they do? And the answer is no. So this survival curve shows you the 5-year relative survival for colorectal cancer patients in the UK, all of them, according to whether their hospital did any research. The bottom, the blue line, where there was no research in terms of interventional studies, treatment studies, no outcome improvement. Whereas if you do some research or a lot of research, actually all the patients do better, with a tiny hint that the more research you do, possibly more outcome. But a 2.5% absolute improvement in survival simply because you're treated in a hospital doing research. And one of the triggers is this fact. The 30-day post-op mortality was reduced by 1% in hospitals that did research. And most of these trials were not about post-operative management. It's about changing the culture in the whole service. And you can see here that there is a hint that those hospitals that did an awful lot of research, which was a minority, may have offered their patients a slightly better treatment. But the volume of research is less important than doing some. So we've got data from the UK, from Germany, and from Finland. And the UK data is commented on here when you look at case mix. That's 3 European countries suggesting if you're treated in a hospital doing cancer research, your patients will live better, will live longer. And interestingly, it's true outside cancer. So these are data on patients treated for a myocardial infarction, according to whether their hospital took part in trials or did not. And there's an absolute improvement in short-term survival from myocardial infarction if you're treated in a hospital doing research. So the first message I would put to you is, actually, it's fantastic that you're motivated to do research, but the real winners if we do research are all the patients we treat, because we will change the culture of the whole service. The trials are important, yes, but actually we benefit everybody we see. And I think that should be one of the drivers as to why we want to do research. The second, clearly, is to answer important questions, which should not just be drug treatments, but other ways of treating cancer as well. Thank you.
Thank you, Professor David Cameron, for this important introduction. Actually, I am proud to participate in this important session in collaboration with the European Organization for Research and Treatment of Cancer, with a long-time collaboration with the National Cancer Institute of Egypt, and with, we wish that this collaboration will extend to another organization and centers here in Egypt. We have a good number of populations, and maybe the feasibility for several studies to be to have an impact for both clinical trial support and the support of healthcare in this country. Thank you. And your second topic in this session will be important selection of early breast cancer patients for chemotherapy, the MIDAC trial story.
Thank you. So I would agree with your comments. I think we are excited by the potential for doing more collaboration with researchers and ultimately patients here in Egypt. What I now want to spend a few minutes talking about is the MIDAC trial, which many of you may have heard of. It's one of 2 trials that have been conducted across the world to answer questions around whether a genomic approach to selecting patients for adjuvant chemotherapy for early breast cancer is better than our current pathological approach. And I'm speaking on behalf of Emil Rutgers, Martin Picard, and Fatima Cardozo, because actually this is their trial, not mine. So you can ask me questions, but if there are any criticisms, I'll pass them on to somebody else. So the background, I showed you this slide yesterday. The background to the thinking is that we've moved away from just what our pathologists can see under the microscope to what we can learn from genomic, and the vast majority of genomic analyses are actually of mRNA, so they're transcriptomic, looking at genomic analyses of breast cancers and saying, can we use that data to offer more effective or avoid ineffective treatments for patients with early breast cancer? And as I commented yesterday, one of the interesting observations for genomic signatures is their most powerful effect is in the early years after diagnosis. And that is the place where chemotherapy seems to have its particular impact. And so there's a logic in using these genomic signatures to ask that question. When should we and when should we not give adjuvant chemotherapy to women with early breast cancer? And these studies, the MIND Act I'll discuss and the US trial TAILOR-X that I will mention briefly, are predicated on this information that the genomic signatures can't yet replace your expert pathologist, but they clearly add to what the pathologist tells you. And so the studies are restricted in terms of which breast cancer patients, because they all assume that if you have, for example, multiple involved nodes, the role of a genomic signature is much less useful because the risk is so high that actually chemotherapy is going to be needed if the patient can tolerate it. Now, one of the things I hinted at yesterday when I spoke, and this is to show you a slide from it because it's relevant to this study, is that if you look according to the risk of the patient using adjuvant online, that online way of analyzing someone's risk of recurrence based on traditional pathology, the MammaPrint 70 gene signature separates out low and high risk in a similar way. So it's around 30%. There's a labeling error on the slide if you look carefully. And what you have is discordance that is around 1 in 3 of all patients. So about a third of the time, the pathologist and the gene signatures give you different answers. So which should we use? That's really the pivotal question behind MIND Act. So let me take you through the Oncotype DX story first, because many of you will be aware of that, and then I'll come back to MIND Act. Because the difference in MIND Act is asking that question. Essentially, which do you trust more, the pathologist or the genomic signature? So Oncotype DX was derived in patients treated with tamoxifen who were ER positive. And this analysis of the SWOG trial, published a couple of years ago in Lancet Oncology, was one of the things that was most provocative about the potential for Oncotype DX to select out patients who would benefit from chemotherapy. So in the SWOG trial, conducted in the 1980s, patients are randomized between tamoxifen or chemotherapy plus tamoxifen. And it's a retrospective analysis of a subset of the tumours for whom the primary could be found and Oncotype DX extracted that is shown here. And in the top left-hand slide, you see the patients who had a low recurrence score, defined as less than 18. They have a fairly good outcome, not as good as we would expect now, but these patients were managed 20 years ago. And you can see between the red and blue lines, the blue being those who got chemotherapy, CAF, and the red line between those who only got tamoxifen, there is no difference in outcome, statistically or visually. On the right-hand side at the top, you see the patients with the intermediate score, between 18 and 30. And you see here that the blue line, which are the patients who got the chemotherapy, may have an improved outcome for chemotherapy when given in addition to tamoxifen. But this is not statistically significant. The p-value is 0.48. So formally, there's no effect. But one can't help but look at this and think, I wonder if the intermediate group do get some benefit from chemo. And down in the bottom right, you see the high-risk group, scores above 31, where very clearly, visually and statistically, the women who got chemotherapy as well as tamoxifen did better. And the difference between these three is statistically significant. So this is a real observation during the first 5 years that the high-risk group get benefit from chemo, low-risk group don't, and the intermediate group we don't quite know. So the question then is posed for Oncotype DX. If you have a patient who is in the intermediate group, what should you do? That's a very different question to MIND Act. The problem is that these numbers are small. And the challenge here is not to say, or rather not to conclude no effect. It's a complex statistical idea. We see no effect in the intermediate group, but actually with small numbers, what size of effect can we exclude? And you always have to remember with a negative answer that it may be negative because there were insufficient patients to give you a small positive answer that would still matter in the clinic. So Taylor-X was designed to address what you do in the intermediate group. They changed the scoring from 18 to 31 to 11 to 25 based on other data. And in the middle group, if your patient is node negative, ER positive, HER2 negative, under 75, because it was not validated in older women, and the Oncotype DX comes out in the middle, what do you do? That's a real clinical question. Well, they are randomized between hormone therapy alone or hormone therapy plus chemo. But Taylor-X presumes that if you get a low score, you should never get chemo, and that if you get a high score, you should always get chemo. And actually, those are maybe not quite such robust conclusions as they would like. In contrast, the 70-gene Amsterdam signature, or MammaPrint, went about asking that other question, which is actually, which is better? The classic pathology review or the gene signature? So this is based on data published some years ago, shown here, where you can see on the right-hand side the risk of recurrence. So the patients in the high-risk group, so they have the color doesn't come across very well, but they have all high expression of these genes. Almost all of them relapsed, and these patients didn't get chemo, whereas those in the low-risk group, where they have, where they don't have the same gene profile, very few of them relapsed. And subsequent studies demonstrated that this gives you very clear separation in terms of the risk of developing metastases. So the good profile group have a very low risk, about 10% risk at 10 years, whereas the high-risk profile have nearly a 60% risk of recurrence at 10 years. A huge separation for distant metastases. So the key question of MINDACT is which is better for selecting for chemo? What the pathologist tells you or what the MammaPrint test tells you. Now, we could have just randomized everybody. The problem is, as you saw, 2/3 of patients, both the pathologist and the MammaPrint agree that they're either low risk or high risk. So what do you do? And if you let the patients choose, that would introduce a bias. So Jan Bogaerts, the EORTC statistician, came up with others with this clever design, which is only randomize when they disagree. Very different to Taylor-X. Taylor-X only looks at the grey area. It ignores the low and high scores because it doesn't actually consider the pathology. Whereas MINDACT takes a different approach. Randomize when the pathologist and the gene signature disagree. So this is the design. It looks more complicated. If your pathology and your gene signature are poor prognosis, okay, we'll give you chemotherapy, because that's two different ways of deciding you're going to do badly. If your pathologist and the genomic signature on the far right say that you have low risk, almost certainly the benefit of chemotherapy is going to be small or nil. But if you're in the middle and the two things disagree, then you randomize as to which one you use. So patients are randomized to say, act on the genomic signature, and if it's low, no chemo. If it's high, give chemo. Or randomized to act on the pathologist, chemo if it's a high risk, no chemo if it's a low risk. And the aim is to reduce the amount of chemotherapy used by between 10 and 15%,